Endo-Perio lesion, you know the one. It's that classic diagnostic puzzle that can trip up even the most experienced dentists, and you know for sure it's going to show up on your board exams. So in this explainer, we're going to give you a super simple, systematic way to just cut right through all that confusion so you can master this topic for good.
All right, so take a look at this radiograph. Right away, you see some major bone loss. And that little tracer point, well, that's showing a really deep pocket. But what's the real story here? Did an infection start inside the tooth and drain out, just wrecking the bone on its way? Or did a perio pocket from the outside tunnel its way in and kill the pulp? That right there is the exact puzzle we're here to solve.
And that really gets us to the heart of the matter, doesn't it? Is this an endo problem, a perio problem, or is it some frustrating mix of both? Just stick with me here because I promise by the time we're done, you are going to have a crystal clear diagnostic path to answer that question with confidence every single time.
So here's our game plan. We'll start with a basic connection between these two tissues. Then we'll map out how they talk to each other. We'll explore why it's a two-way street of disease. And then, this is the big one, we'll dive into the classifications you absolutely have to know for your exams. And finally, we'll wrap it all up with a solid plan for diagnosis and treatment.
Okay, first things first. The pulp and the periodontium, they're not just separate neighbors living next door. They are super intimately connected. It's kind of like one tooth being supported by two tissues that are in constant conversation. And really, getting a handle on that relationship, that's the absolute key to unlocking this whole diagnostic mystery. So let's get a clear definition. What is an endoperio lesion, really? Well, at its core, it's just a lesion where you have inflammation in both the pulp on the inside and the periodontal tissues on the outside. And it's that shared inflammatory mess that creates the puzzle we're trying to solve. All right, so if these tissues are so connected, how does a problem actually spread from one to the other? Well, it all comes down to these pathways of communication. Think of them like highways. If you can understand the routes, you can pretty much trace any problem all the way back to where it started. We can basically break these pathways down into three main groups. First, you've got the natural anatomical pathways that are just built into the tooth. Second, there are non-physiological pathways, ones that are carved out by disease. And third, we have the iatrogenic pathways, which, unfortunately means they're the ones we sometimes create during dental procedures. So let's look at the natural anatomy. First, you've got the dentinal tubules. Then you have lateral and accessory canals, those little side channels that branch off the main canal. You see them a lot down in the apical third and especially in the furcation area of molars. And of course, you've got the apical foramen. That's the main highway at the very tip of the root. But it's not just about the natural anatomy, right? Diseases like root resorption or really deep root caries can literally carve out brand new pathways. And then you've got those iatrogenic issues we mentioned, the operator-induced stuff. A perforation during a root canal or a vertical root fracture, boom. That creates a direct superhighway between the inside and the outside of the tooth. Now, this is super important to remember. This is not a one-way street. The influence between the pulp and the periodontium goes both ways. It's completely reciprocal. A problem that kicks off in one can absolutely cause a problem in the other, and vice versa. So how does that actually work? Well, think of it like this. On one side, you have perio disease. It can expose those little lateral canals, letting bacteria travel inward and infect the pulp. We call that retrograde pulpitis. On the flip side, and this is actually more common, you have an infected pulp. The bacteria can drain outward through the apex and cause bone loss, and that's what we call retrograde periodontitis. Okay, so now let's see how all this builds into the classification system. And listen, this part right here, this is the absolute heart of what you need to crush on your exams. Getting this primary diagnosis right is, well, it's everything. It dictates your whole treatment plan and basically predicts your prognosis. First up, we've got the primary endodontic lesion. This is where the problem starts inside the tooth. Think deep decay, maybe some trauma, or a leaky restoration. The infection then finds a way out, usually through the apex or a lateral canal, and starts destroying bone, which can end up looking exactly like a perio pocket. So how do you nail this diagnosis? Okay, here's a huge clinical pearl for you. Look for a deep, solitary, narrow pocket, especially in a mouth that's otherwise pretty healthy periodontally speaking. But the number one, absolute most critical diagnostic key, the pulp is going to test non-vital. And the best part about this? The prognosis is excellent. You just do the root canal and you're golden. In this case, it just illustrates that point perfectly. Look at this first radiograph here. You can see that huge area of bone loss around the root tips, right? Now look at this other image. After doing nothing but a root canal, look at that. The bone has completely healed. I mean, that's your definitive proof right there that the problem was 100% endodontic from the start. All right, now let's completely flip the script and talk about the primary periodontal lesion. With this one, the infection starts on the outside. We're talking good old-fashioned plaque and calculus. This creates a perio pocket that slowly works its way down the side of the root, and it might not even touch the pulp until much, much later. And how do we spot this one? Well, you're going to see signs of generalized perio disease everywhere. Plaque, calculus, typically wider pockets. But again, what's the single most important test we can do? You guessed it, pulp vitality. In a primary perio lesion, that tooth is going to be vital. And here, the prognosis is all about how successful the perio treatment is. Of course, it's not always going to be that black and white, right? Sometimes you get these combined lesions, where an endo problem and a perio problem literally merge and become one giant lesion. And this is where the diagnosis can get really, really tricky. And we can even break these down a bit further. You could have a primary endo lesion that gets a secondary perio infection. Or the opposite, a primary perio pocket that gets so deep it finally kills the pulp. You can even have a true combined lesion, where two totally separate diseases just happen to merge. The bottom line with all of these, the prognosis is a lot more guarded, and you absolutely have to treat both issues. All right, so let's put all the pieces together now and talk about a clear diagnostic strategy. After that, we'll take a quick peek at some advanced treatments for those really tough cases. Okay, this slide right here, this is your ultimate cheat sheet. It lays out the classic signs for you. Pulpal disease, often severe, acute pain with a narrow pocket. Periodontal disease, usually more of a moderate, chronic thing with wider pockets. But just look at that fourth row. Seriously, if you only remember one thing from this entire explainer, make it this. The pulp vitality test is king. It is, without a doubt, the single most important clue you have to solve this puzzle. But what happens when the usual treatments just aren't enough? Well, for teeth with multiple roots, like molars, sometimes we have to think about more advanced surgical options. For instance, if you've got severe bone loss, but it's only on one root, or maybe one root is fractured or just completely destroyed by decay, a procedure like a root amputation might be the only shot you have at saving the rest of the tooth. And here's what that actually looks like in practice. You can see the surgeon finds that one hopeless root, surgically removes it, and then carefully reshapes what's left of the tooth. What this does, effectively, is turn a molar into something more like a premolar, which is way easier to clean. It's a fantastic way to save a tooth that would have otherwise been extracted.
And that brings us right back to the beginning. So when you're staring at that confusing radiograph and you're probing that deep pocket, what's the single most powerful tool you have? It's asking that one simple question. Is this pulp alive or is it dead? Because that answer right there is going to guide your entire clinical journey.